Please welcome to the stage Adam Wheeler, MD, founder, Big Tree Medical Home. Bibb Beale, founder and CEO, Frontier Direct Care.
Hey guys, my name's Adam Wheeler, and I think we had the physician without original sin up here earlier. I think I'm more like the DPC Jeremiah. There are a few people left at that. All right, so if you guys remember Jeremiah was like the prophet in the Bible that would bring up the inconvenient truths, and everybody hated him, and they ended up killing him. So that's kind of my job. I've got some inconvenient things to bring up. I think I'm unliked in general because, first of all, I'm a pediatrician. So all the pediatricians shout out. Exactly. See, I'm the only one here. Two over there. All right. I know how to make it work if you guys are still struggling there. Secondly, I've got this fantasy about working for private equity. Okay. See, no one laughed at that one, right? So I just seriously, I think private equity is the coolest thing ever. And I think I missed my calling doing pediatrics because I would have had a lot of fun in that world. The third reason that I'm really unliked is I love mid-levels, okay? And that just that got me in trouble because mid-levels don't want to be called mid-levels. And then if you don't like mid-levels, then you don't like them. So I'm old too, so I always slip and use mid-level. I apologize for that, but it's quicker than saying physician assistant, nurse practitioner, assistant physician. And that third group is a whole nother thing. If you haven't played there, it's a very interesting space. So we're gonna bring up some inconvenient things, okay? And you'll see my love for mid-levels come out. Okay, so this is back of the envelope math. If you're actually the expert that put this data together, I apologize if I screw it up. But the U.S. has about 500,000 primary care physicians, okay? And I think there's a slide before that. There it is. Okay, go with that in a second. All right, this is a map. This is a current map pulled off the government website. And each county in those boxes is an area that's a primary care shortage area. Okay, my theory as to why VC firms don't like to play with direct primary care very often, with some notable exceptions, is that they live in the gray areas, okay? But for the rest of us who live in green areas, where it's 6 to 9 months to get an appointment, you know that this is real, right? And we all know it's getting worse, right? So the AAMCs thinks that we're gonna be 48,000 primary care physicians short by the time we get to 2034, okay? And we don't care about the non-primary care physicians, so we've got about 500,000 of us out there, okay? Now, let's just say that 10% of those people take up the banner that has been lifted here at this conference, all right? And we add 50,000 primary care physicians. Now, who are doing DPC. Now, what's the problem with that? Well, who here does have original sin, those of us that played in the fee-for-service world first, how many of you have a bigger practice today than when you went into DPC? My hand is raised, okay? It is possible, all right? The reality is, though, most of us are planning to cut our practice size in half or by 2/3 moving to DPC. Now, what does that mean for the primary care shortage? We all know that we're not training any more providers, right? So the math turns out to be a 50% increase in the primary care shortage. If, on the other hand, we get 10% of the primary care docs to change over to DPC, but to develop what I call a team-based approach, okay, and I mean a full team, just that 10% of PCPs could take care of the entire population of the United States. Okay? That is a powerful difference. We move from a shortage to an excess. just by changing the business model. So the question is, of course, how many patients should a DPC doc take care of? We were talking about this over lunch, and some of the vendors were asking me how many patients a DPC takes care of. And I said it's kind of a badge of honor. So the lower you say your cap is, like the increased status you have in the DPC community, right? That's like half a joke. So when I'm a pediatrician, I don't know what 15-minute visits are, right, or 25 patients in a day. So we'd start at 42, and if we needed to, we'd get to 50. All right, that was my day before I switched. And I switched for all the mental health reasons that people have been talking about. My practice moved from 2,500 patients to 5,000. Now, how, right? Well, we have 5 mid-level providers that work underneath me. Each of them has 800 to 1,200 patients. We have other collaborators too, so we see adults as well. And we go up to, and we don't take anyone over 65, okay? And they yell at us, but when we say we love them, that we just don't take those patients. We also have 6 RNs, so we don't have any MAs, we have RNs. We use Spruce, and my 6 nurses are basically manning Spruce, doing all the messaging with the patients. They're doing all the scheduling, setting up the refills, doing all the paperwork. Each of our providers sees about 15 patients a day. That's including me. I see about 15 patients a day. 5 days a week. That's 22,000 visits a year, which is 4.5 visits per patient per year, right? That's more than 2 times the national average, okay? So we're providing a much higher level of access than traditional primary care, but my one MD is now spread over 5,000 patients. So we're still providing the level of access that we know and love as a part of DPC, but we're spreading out doctors in such a way to actually deal with the primary care shortage area. We also have pharmacists, counselors, and dietitians that we add in so that the counseling about diet is not done by me, okay? We have pharmacists because my nurses were doing our dispensing, and I really thought, these nurses could be doing messaging, and the nurses were counting the pills, right? Legally, I was dispensing, I get it, okay. So the nurses are counting the pills, right? And I'm like, I wish I could find somebody who all they wanted to do in life was count to 30, right? And then my nurses could do nursing, and then they could, but who would want a job like that? And my wife, who's our operations COO, she said, I think they call those people pharmacists, right? And of course, I know pharmacists do more than count to 30, but still, so we opened a pharmacy instead of having a dispensing clinic, right? So again, how do we spread out that one license? Each of the persons on the team operate at the top of their license so that the primary care shortage can actually be addressed by this movement, not worsened. So this is our model, and just so people understand what we're talking about. So if you're an investor, could we make a new model that uses what we've learned from DPC, but actually try to address the big problem in our country, which is primary care shortage? Yeah, so we've got 20% margins. We've got about 6,000 patients on monthly plans and another several thousand patients who see us on an as-needed basis and pay us cash. We give them all their meds for free, their generic meds for free. We've got data that, net promoter score of 89, like, everyone in the room does. But we've been able to demonstrate a 20 to 40% reduction in the total cost of care. About a third of our patients are uninsured, and almost all of our patients live in primary care shortage areas. Okay, so in my mind, this is kind of a mission accomplished. The model works. So Bibb is actually a better business guy, so he's going to come up and talk about some of the business implications about expanding models.
Thanks. 2 things. I have severe ADD, and Kelly that works for Frontier, so my team said, you will write your notes down because you have been known to break out in a couple random stories. And so I have a limited time frame, so these notes will help keep me on track. So also another thing, I know a lot of you out here are doctors and went to school for 8 years. I also went to school for 8 years to get my bachelor's degree in business. So we do have some things in common. My name is Bibb. I work for Frontier Direct Care. I am a multifamily real estate developer and contractor by trade. They got roped into this DPC movement by Dr. Peter Lazapina, and have done a couple of other random things like sell containers of chicken feet to China, and get Joe Wilson that works for Frontier out of Mexican prison. So we can tell you that story tonight over drinks. It's really great. Joe is a theatrical speaker too, so he would be more than willing to act out how he had to describe to a Mexican prison guard that he has a mariposa, which is butterfly, on his back as a joke, and which caused him to stay in jail for like another day. So anyway, so that's a little bit about who I am. I wanted to start. We're supposed to be talking about growth right now, right? And so Frontier has had the awesome opportunity to be experiencing lots of growth over the past 2 years. But there's a couple of things that I wanted just to touch on, really fundamental strategy for growth. And that really starts, my philosophy and our philosophy in Frontier, strategy of growth, starts with really 2 main core values. And so number 1 is do hard things. And number 2 is experiences over comfort. And, I am a betting man. I was going to say, if I was a betting man, I am a betting man. I would guess that a lot of you here today have the same type spirit and attitude. It's why you're in DPC. It's why you chose to buck the system and be in the DPC movement. And so these are 2 of the main things that kind of make up Frontier and how we've been able to have this philosophy of experiencing this fast growth. So thinking a little bit about the DPC market, it's very obvious. If any of you read the DPC Trends Report, it's great. It really showed that there's a substantial amount of demand in coming from members saying, hey, I want to experience healthcare this way. I want to be in this type of primary care. And at the same time, we see that there's a lot of PCPs that want to deliver healthcare model this way. But, we are in a precarious spot in the DPC movement that we have this responsibility to try to attain this growth. But the reality is we're growing slower than the demand is. And so just like you, over the pandemic, we grew, but also as we continue to grow over that pandemic, it didn't come without the demands and the pressures, demands from your patients saying like, hey, I want to get in, I want to practice this model with you, and those pressures of, hey, how do we do that and how do we grow in a sustainable manner? And so one of the things that Frontier has been highly focused on is how do we have sustainable growth? And so if we look at what we did, last year was really our first big growth year, is getting out, building a team. And so we grew to about 3,000 patients over the course of 1 year, and built 5 locations. And then this year, we're going to grow from about 3,000 to almost 20,000 patients and have 12 locations. And so that comes with a lot of demands and a lot of stress and pressure that I'm sure a lot of y'all are feeling as well. And so when we think about that growth as DPC, DPC owners, and or maybe you work for a DPC, but as we think about how do we meet this demand? One of the things that we've been doing is we wanted to build a scalable model that would create a platform that would also create sustained growth. So how do we grow 600% year over year inside Frontier? Well, it's this platform idea that we're trying to create. And so really what that platform works out to be is we've created an engine that's kind of underneath the hood of the practice. And so no one really knows who I am or what it is that I do, or Jesse or Joe or our other people on our corporate team. They don't see us or hear from us or know what we are, but we are this engine behind this platform that our medical staff get to operate in and get to lead. And so our focus has really been on how do we remove those pressures that we're feeling on this growth and keep those away from our medical staff by supporting them really well. So removing all the frivolous admin and billing and tracking down missed payments and all this other crap that a lot of y'all have to do. The way we've been able to sustain this growth or continue to grow at the rate that we're growing at is by creating this engine under the hood that helps handle a lot of that. So when you can allow doctors and mid-levels like yourselves to practice, then what happens is you truly are restoring the doctor-patient relationship. And that's really what Frontier is trying to do, is grow really fast without sacrificing the result and restoring that relationship. And so, as we've been doing this, there's a million stories that we can share, but right here, y'all can see this is Dr. Suja Perikathu. Dr. Perikathu is our lead of our platform at our Brownsville location. And she has this really interesting story that she tells a lot when she speaks with other employer groups or other individuals, where she was working in fee-for-service for 10 years. And throughout that 10 years, she had this one patient named Emily. And Emily had struggled with diabetes, had an A1C level that was always hovering right around 11, and had been seeing Emily for 11 years. Well, she quits and comes and partners with Frontier, and through that, within 3 months, Emily saw her A1C levels go down to 8.3. So we know it's working, right? We know what it is that we're doing in this DPC movement is actually working, and it's truly changing people's lives for the first time. But how do we do that in such a way where we don't pervert the DPC model and put so much stress on people like Suja to say, you got to take more patients, you got to do more of this, you got to do more of that, that ends up breaking her, and we become the same damn thing as fee-for-service, right? And so what we've tried to do is build this platform that focuses on releasing Suja from all of the other things that she had to do and just allowing her to elevate and focus on what it is she got into medicine to do in the first place. And so we see that working, right? So thinking about what is it that we have put together to help us experience this growth. And so this is the part where you're expecting some like meat on the bone, where I'm going to give you like these 3 life hacks, but I'm giving you these very 3 ambiguous points that you're going to say, well, what the hell is this? And then I'll offer up to the rest of the Frontier team. They'd be glad to talk to you more about it. So what have we done that helps scale and grow to create really sustainable growth? And so number 1 is know your goals. What we've tried to focus on is saying, hey, this is our roadmap. This is our 10-year target, our 3-year picture, and our 1-year plan. And we measure those on a week-by-week basis. And everyone knows, everyone has a goal each quarter. We're measuring those goals each quarter, and they know exactly what the roadmap is of this growth in Frontier. And so they know how to get there and what to do and exactly where they're pulling on the rope with the rest of the Frontier team. And so, but you got to define what your goals are first, and then after you're able to define your goals of the company, then as an employee of Frontier, I understand how I play a role in that and where I need to go to help achieve that goal. The next thing is know yourself. And so, we use Traction. There's a book called Traction by Gino Wickman. It's an entrepreneurial operating system. It is incredible to help take what is in your head as a leader and help get it on paper and paint a picture for your team where they can participate with what's on your head. So I'd highly suggest that you implement that. There's lots of good resources on the internet to do that too. We're more than willing to share with you about what we do with Traction. We've been using it. I've been using it in other companies prior to this, but also in Frontier, and it's extremely helpful, especially going back between kind of office staff and the medical staff. There's a lot of things that are lost in translation, and so Traction has been really helpful with that. So next point, know yourself. We use a system called Cultural Index to help us understand who we are as individuals in Frontier. So I'm very aware of who I am and what it is that I'm really bad at. Suja, who's our lead in Brownsville, she's very aware of what she is good at and what she's bad at. And through understanding who we are as individuals working inside our business, what we're able to do is Suja's able to go practice being a doctor, and I'm able to go practice casting vision for our company. If Suja and I were to trade places, I would just label everything as an ant bite and say, you'll probably be okay. I don't know, look on the internet, right? you got to know who you are, right? And so once you know who you are, then you can start to discover who your team is, and then you can start to really put together a team. And so that's really the third tenet that Frontier is using, is building a team. And so I make the joke a lot of times throughout the course of the day as I'm meeting with investors or potential business owners. They'll ask me a question, and I won't know the answer most of the time, and I'll just be like, I don't know. I don't know who does that. Someone here does that. I know they're doing it, right? And they're like, well, how do you track this and that? And I'm like, I don't know. It's not my job to know. My job is to be right here, right? And to convince you to sign up. So when you know yourself and you know where you're going, and then you can start to build a team around that, as leaders, it gives us the ability to let go of the vine and to step away and to let doctors be doctors and nurses be nurses and sales staff be sales staff and accountants be accountants, right? And so that's what it is that we're trying to do at Frontier, and we've built this engine that is behind the scenes that's supporting the doctors and creating a platform for our medical staff to be able to come in and practice medicine the way they wanted to when they were a kid and wanted to get into medicine in the first place. So there's a lot of nuts and bolts of these three tenets. We'd be more than willing to share with anyone. Come find any of the Frontier team, and we can talk about that, the nuts and bolts of how we get this done. We want to share with you our entire playbook. We have been lucky enough to unlock a couple of ways that we can grow really fast and do so in a manner that stays within budget. And so we'd love to share that with you. Please come find us. We're a firm believer that rising tide lifts all ships. So as we close up and get into questions, I wanted to share with you one thing about Frontier. Our unspoken core value is we are up for anything and down for a bar fight. And yeah, I know it's a little aggressive, right? But that's who we are, right? And so we're not, we don't shy away from adventure or doing hard things, just like you. And we want to fight alongside you. And so please come ask us what we're doing. We'd love to share with you our story and hear your story. So our team's here. In fact, they're already at the bar. So if you can't find us, we'll probably be at the bar later on. Yeah, so excited to share with y'all more. So, and want to open it up to some questions. Adam and I field any questions you might have. Said great presentation. We're the best so far.
Yes. Okay. I want 10,000 patient panel, man. You've inspired. So some other math just to contemplate. If you want to spend 1 hour a year with your physician, so let's say 30 minutes for a physical, which would be short for most of our standards, maybe 2 15-minute encounters, not necessarily face-to-face, let's just say an email, texting. That's 1 hour. How many patients can you have in a 2,080-hour work year? The math is 2,080, right? 2,080 times 1 is... So you have.
I just told you I went to school for 8 years.
So
you're asking me to do math in front of everyone?
A panel of 2,000 patients, right? So if you want to spend 2 hours with your doctor every year, which a lot of us are saying, oh yeah, we want to do 90-minute, get to know you encounters. Well, now you can only see half that. Your panel can only be 1,000. So your math is spot on. I mean, when people say, oh, we can't all do DPC because we don't have enough docs. I mean, you have one solution, add a lot of mid-levels, and that's awesome. But I think the other reality is, who wants to be a primary care doc in the old system? If we suddenly have reasonable lifestyle, now people want to go to school to do this, you'll get more numbers over time. That's how the free market works. It actually will correct itself over time. We should have either smaller panels or we should have bigger teams, but we should not have small teams with large panels, and that mathematically, works because you can only see 2,000 people on a panel if you only spend an hour with them.
Yeah, and unfortunately, it's not a free market, right? So the number of residency slots is capped. And so the reason that the number, but the residency slots are capped. So even if you go to the Caribbean Med School, and I have 2 physicians that work in my practice who went to a Caribbean Med School and couldn't get a residency spot, despite the fact that they did as well on their USMLE as I did. And they're graduated from U.S. colleges, born and raised in the United States. So it's not an English question. It's just there aren't enough residency slots for people to get in. And so functionally, the number is capped. And that's why I say, okay, I'd like to change that. Congress, please help. Or we could, I think the AAMC has a role in that as well. Alternatively, we have this group of clinicians who I've never met a PA or an NP who says that they're better than a residency-trained family medicine doc. They don't think that, but they still have a role in the team. And until we can increase the number of residency slots in the country, the only viable alternative is to use mid-levels.
Just to note, we use mid-levels in our practice too, and so everyone's overseen by a doctor. It's worked out really well.
So, is it on? Okay. I have two questions. One, so I'm an internist, like the pediatricians. Any internal medicine physicians? Yes. So nice to see you. Okay. In our board certification, nobody is doing primary care in internal medicine. So when I finished, back when dinosaurs roamed the earth in 2002, there were 25 residents in internal medicine, and 20 of us became outpatient docs who saw our patients in the hospital, and we've lost those doctors. So I don't know if there's any interest in anybody of starting to go back to the hospital. That's something we haven't really talked about. I don't know if we can do that. And that's probably not for today. But my other question I had for you was, in terms of supervising 5 mid-levels or allied health professionals or whatever, how do you do that and see 15 people a day? Is this a trust thing that they come and get you when they need you, or do you have to go through all of their cases, or is it you kind of worked out a nice knowledge level, like they know when they don't know to call you? How does that work in a practical day?
Yeah, it's a good question, and that's, certainly not every mid-level provider is cut out to do the job that I have people do. And I see it as a training process. So I think of them like I would think of a new intern or maybe a fourth-year med student. And then there's a training process. So at the beginning, I'm seeing every patient with them. And so I schedule my patient load really light. And then as they, Andrew Doppelt's been with me for 4 years, and he's better than I am at a lot of things, to be honest. Another clinician, I'm going to work with them a lot more. We're also co-located, so they can grab me at any time. And then it is DPC, so we've got lots of time to see the patients. And I still have enough of my bad habits that I learned from fee-for-service, and so I'm too fast to, 15, I used to have 15 patients in the morning, right? So, I'll see an ear infection real quick and then run over and look at a couple of patients. So it's a process, and it certainly depends on the personality, but it's also training. You're training them, and so they get better and better over time.
I think we have time for maybe one more question. That's it. We're done? Oh, we're getting the light. We're done. I think we're done. Thanks. Feel free. I'm sure Adam would be more than willing to talk with anyone that has questions on mid-levels. Dr. Reliza Pina here is in the back with the Frontier team. He was the genius behind using mid-levels at Frontier too. So feel free to come talk to them or talk with any of us about business strategy and stuff. We'd love to talk with you further. Thank you.